بسم الله الرحمن الرحيم. مساء الخير عليكم جميعا. هاي الفعالية ضمن فعاليات كلية الصيدلة، الجامعة الأردنية. نقوم يعني بعقد بعض المحاضرات التوعوية، وهي إلى حد ما بتكون مهمة للمختصين وكذلك للكثير من الصيادلة، لأنه بنحاول قدر الإمكان أنها تكون ذات مستوى متوسط بحيث تناسب الجميع، فإن شاء الله بيكون فيها الفائدة. بنرحب جميعا بالدكتور أحمد حنيف. بس أحكي سريعا البايو فور دكتور حنيف. دكتور حنيف holds a BSc degree from the University of Jordan, Faculty of Pharmacy in 1998. He worked in pharmaceutical companies in the Middle East for 13 years. Then he completed a PhD in pharmaceutical and pharmacological sciences from West Virginia University in US. His research project was focused on cardiovascular pharmacology, specifically the coronary response to ischemia. Shortly after graduation, he joined the School of Pharmacy at West Virginia University as an assistant professor, where he has been involved in teaching multiple classes in PharmD and PhD programs. Furthermore, he has been acknowledged 4 times as the outstanding teacher of the year every year that he has been eligible for. So again, more than welcome Dr. Hanif in this evening activity, and we hope that we get a benefit out of this lecture, and the mic is yours. So please go ahead.
السلام عليكم جميعا، مساء الخير. احنا عندنا لسه الساعة 11 صباحا. شكرا دكتور محمد على التقديمة اللطيفة. شكرا على الدعوة وشكرا للحضور. نعرف الوقت عندكم متأخر، بس إن شاء الله يعني we will try to make it as focused and as beneficial as possible. I will start sharing the screen, and I would be happy to take any questions after I'm done with the presentation.
ممتاز. تمام يا دكتور، السلايدز واضحة بالنسبة لنا. تفضل.
So دكتور محمد شايفين اللي هو الفول slide presentation. تمام. So the topic we agreed to present or discuss is the drugs used against autoimmune disorders. And the objectives for this less than 1 hour lecture is to explain the concepts of immunological tolerance and immunity continuum, where I will be introducing the concept of autoimmune disorders, then defining the different types of dysfunctional immune disorders, the general pathophysiology, and the challenges associated with the management of this disorder. And this is the main core of the presentation, which is to describe the pharmacological approach to managing these disorders. So starting with the immunity continuum, and I would like to use this. So in order to have, they call it the 34,000 perspective of these disorders, I have this continuum where we have in the middle here, we have normal immune function, and that smiley face, whereas on the left, we have deficient immunity, as we have with AIDS, for example. And on this side, we have dysfunctional immunity. So these are the examples, and here where we will be focusing our lecture. So dysfunctional immunity can be divided to either overactivation of the immune system or misguided immunity. Here comes the concept of immunological tolerance. As you know, our bodies continuously produce self-antigens. And these antigens, they are called antigens because they have the potential to induce an immune response. They are produced by our bodies. And
بليز بيان أنا بعمل لك ميوت من عندي خلاص.
So these self-antigens are part of our body, and our immune system is supposed to tolerate these antigens and not to start an immune attack. And the same applies to the fetus in the womb of the mother, because half of it is antigenic, it's from the father. So the same mechanisms that mediate immunological tolerance are the ones which also mediate our tolerance to the fetus in the womb of the mother, or the commensal flora for that matter. And when our immune system starts to attack these self-antigens, this is what we call autoimmune disorders. At the same time, in light of foreign antigens, we would like our immune system, as you know, to attack these foreign antigens in what is known as immunological response. But if we have an overactivation of the immune system against these foreign antigens, then this is when we have the hypersensitivity disorders. So again, foreign antigens we want to attack, whereas self-antigens we want to tolerate. When it comes to disorders, when we have misguided immunity, then we have the autoimmune disorders. And when we have overactivation of the immune system, then we have the hypersensitivity disorders. So examples of autoimmune disorders, as you know, we have the famous but notorious type 1 diabetes. Then we have multiple sclerosis, lupus, psoriasis, so on and so forth. We have a long list of autoimmune disorders, whereas for the hypersensitivity disorders, we have few examples, but they are far more widespread. We have asthma, atopic dermatitis, and allergic rhinitis. And in my talk, I will be focusing mainly on the management of psoriasis and atopic dermatitis, and I will mention the reason for that soon. So autoimmune disorders are, diseases in which our immune system mistakenly attacks our body. These are chronic and often lifelong disorders. We have a long list of autoimmune disorders, and scientists have identified more than 80 immune diseases. These disorders, according to the National Institute of Health here in the US, they affect 5 to 8% of the US population, which is around 330 million. So this is a sizable number we are talking about. And the other thing is that the incidence of these disorders is increasing. And here I'm referring to autoimmune disorder as AID with a small s. So the incidence is increasing. We do not really know the exact cause, but a number of hypotheses are there, including more urbanization. People are moving away from rural environments to the cities. The hygiene hypothesis is possibly another cause for that, but these are all hypotheses. The other thing about the autoimmune diseases is that they strike women 3 times more than they affect men, and this is for all of them. We have some of them in which we have equal prevalence, whereas others we have more than 3-to-1 ratio. The etiology, unfortunately, we do not know the etiology. However, we know that we have 2 important components that play a role in the etiology and the progression of these disorders. So genetic predisposition, and this is documented for almost all of the autoimmune disorders, as well as the environmental factors which will trigger the genetic predisposition. And I would like this analogy, I'd like to use this analogy where this metaphor says genetics loads the gun, but the environment pulls the trigger. So basically, people who are born with genetic predisposition, they have that predisposition already in their genes, and they are waiting for the right time to be triggered. And for the most time, we have the environmental factors as well as, the age and other factors that may trigger or actually start the manifestation of these disorders. Pathophysiology, although again, we do not know the etiology, our understanding of the pathogenesis or the natural history of these disorders has been improving dramatically. We have been able to identify genetic dysregulation, certain loci in the genes of patients with autoimmune disorders have been known and characterized. But the problem is that oftentimes we have multiple genes involved. So we are working to understand the interplay between these genes and how this would lead to the actual manifestation of the disease. Our understanding of the pathogenesis has allowed us to come up with multiple pharmacologic agents and multiple targets that we can target in order to help these patients have as normal life as possible. And when I go back to my, in the 90s, when we studied autoimmune disorders, we had a limited list of drugs that were available. Many of them were not specific, and many of them were associated with serious adverse effects. The other thing related to the pathophysiology is the actual classification of these disorders. Up until this moment, we are classifying these disorders as system diseases or organ diseases. So for example, here we have psoriasis. It starts as a skin disease, but then can spread to other parts of the body. We have ulcerative colitis, Crohn's disease, they affect the gut. We have rheumatoid arthritis or juvenile arthritis, they affect the joints, whereas ankylosing spondylitis, they affect the spine, and this is psoriatic arthritis. So this is how we have been classifying these disorders. And here on the right, you find that, the different organs or parts of the body that are affected in these disorders. However, this organ-based concept is changing now, and there are researchers and scientists who are calling for a therapy-based approach in which we have signature cytokine-based concept. Here, the same disorders, we have them here, but instead of classifying them according to which part of the body is affected, we are classifying them based on which inflammatory cytokine is involved in their pathogenesis. And for example, here, interleukin-17 is involved in ankylosing spondylitis, whereas interleukin-23 affects multiple gut disorders. So this approach will help us better approach the pharmacologic choices when we treat these disorders. This is still in progress, but this is a 2022 paper, and I believe that that will have an impact on how we view and classify and therefore manage these disorders. The cytokine network, this is actually the essence of how we understand and how we will be treating these disorders. Here we have multiple autoimmune diseases, and the cytokine network is basically the different inflammatory mediators known as cytokines, the communication signals amongst the different immune cells, which result eventually in the signs and symptoms of that disease. So our understanding of this network will definitely help us, as it has been helping us in coming up with new treatment options that are far more effective and relatively safer. This is, as you can see, a very complex map or network of how these cytokines are interacting. But with research, we are hopeful that we will be more selective in our understanding, as well as in the treatment options that we will choose. The other thing, as you can see, that a number of these inflammatory mediators, we have tumor necrosis factor alpha, interleukin-1, so on and so forth. All of these, or most of them, are being targeted pharmacologically now with the advancement of the pharmaceutical manufacturing processes that have been developed in the past 2 decades. Diagnostic challenges of autoimmune disorders. A common feature for autoimmune diseases is that they have variable presentations. Even the same patient will present in a different way from time to time. 2 patients will have widely different presentations. There are things which are in common, but still we have that spectrum of presentation, which makes the diagnosis somewhat challenging. The other thing is that a good number of autoimmune diseases, they have no specific lab finding or diagnostic test on which we can rely as an objective test. So, for example, we have to rely on the signs and symptoms only when we diagnose patients with atopic dermatitis and psoriasis. We do not have a reliable objective lab test or any clinical test that will help us actually diagnose these disorders. Whereas lupus, for example, or systemic lupus erythematosus and rheumatoid arthritis, in addition to the signs and symptoms, we can rely on certain clinical or lab findings in order to diagnose these disorders. Another thing related to the diagnostic challenge is the environmental triggers and the risk factors. We mentioned that patients are genetically predisposed, and based on whatever environmental triggers are taking place in their lives, then that will impact how quickly they will have the disease in their lives and how far it will progress. So, for example, in rheumatoid arthritis, we do not really know the environmental trigger. It is something, there are certain hypotheses, but we do not really know what starts the immune system to attack the joints and cause the disease to progress. Gender, as we mentioned, these diseases are generally more prevalent in ladies. For example, lupus is 10 times more prevalent, and rheumatoid arthritis is 3 times more prevalent in females compared to males. So we have that disparity as well. Age, we have psoriasis. It peaks in the 3rd and 6th decades of life, whereas atopic dermatitis, which they have a number of things in common, it is more of a child disease. It presents in early childhood, and usually children grow out of it, as we will see. Sunlight exposure, it's an important triggering factor and something which we will be alluding to when we talk about psoriasis and atopic dermatitis. We have also the factor of race or ethnicity, and this confirms the genetic role for these diseases pathogenesis. Psoriasis is more common in whites, whereas lupus is more common in non-whites. We have a long list of drugs which are considered as trigger factors. Some of them, they affect the epigenetics, such as hydralazine, which is something important in patients with lupus. Smoking, definitely important factor, and it can even affect the efficacy of some drugs as well. Alcohol consumption and stress are also some well-known triggering factors. The point here is that, you as healthcare providers, either in your pharmacy or in the clinic, you will be playing a role in patient education. It's important for them to know which the triggering factor is and how to avoid that. So before we go and start talking about the management options we have, I would like to give you a 1-minute break. This I do this in my lectures because I know, on one hand, the material is abstract. It can easily become boring, and I know it's kind of late there. So I have this, quick break in my lectures every 15, 20 minutes. And this is something I actually use for my students here at WVU. So as you can see, we have difference in color. So, and I asked them, what is this and where it is located? Of course, you all know this, guys. So what I want to say is that, I also represent Jordan when I talk about science here in this school. Most of my students, they like this 1-minute break because they say it helps them, regain focus, and I hope it did the same for you. All right.
Great idea. Great idea, I said. Great idea. It's good to promote Jordan over there.
So I'm going to increase the tourism in Jordan.
Okay.
All right. So moving on with the management options. And I was thinking about talking about the autoimmune, the drugs used for these disorders in general, but I thought it would be more useful for the audience if we focus our presentation on these disorders, which are psoriasis and atopic dermatitis. And the reason is that, number one, psoriasis is an autoimmune disorder, whereas atopic dermatitis is a hypersensitivity disorder. So from pathogenesis or pathophysiology point of view, they are different, they overlap, but they are different. The other thing is that both of these, they have topical as well as systemic treatment options. The systemic treatment options will be very similar to other autoimmune disorders when we talk about psoriasis. So hopefully that will meet the goal of this presentation. So starting with psoriasis, and again, this is something I try to tease the brains of my students when I present to them, and I ask them what this is. This is actually a clapper from the Middle Ages. It is something to make sound. And as you might expect, back in those days, people thought that psoriasis was contagious. So any patient with psoriasis was required to have a clapper like this whenever he or she goes to a public place, for example, the market. And they would be making sound with this so people would move away. This is, and speaking of bullying these days, I think this is far worse than that. So this tells you as a healthcare provider about the psychological and social impact of psoriasis and how much it would impact these patients negatively. So just, a quick reminder of what psoriasis is. It comes from the Greek word psora, which means to itch. It is a lifelong, non-communicable, so again, it is not contagious. It is an autoimmune disease that is painful, disfiguring, and disabling. So it is a systemic disorder, although it starts in the skin, but systemic complications or extracutaneous complications are reported, and they are quite common in this disorder, especially after the 7th decade of life. It is quite prevalent, around 2% in the general and worldwide. As I mentioned, it's more common in whites, and it could occur at any age, but it peaks in the 3rd and 6th decades of life. It affects both males and females equally. So the treatment goal, of course, we want to prevent those well-demarcated skin lesions that are scaly, they are rough to the touch. So we want to prevent that. We want to treat it, prevent relapse, and most importantly, provide remission that would improve the psyche of the patients as well as to prevent future comorbidities associated with this disease. So the non-pharmacologic therapy is important as well. Speaking of stress reduction, this is one of those things which is easier said than done. Some things you cannot control in your life, I assume. Keeping the skin moisturized is important, and using sunscreen because the sunlight exposure is one of the important predisposing factors or triggering factors in these disorders, both psoriasis and atopic dermatitis. The water they use for bathing should be tepid, not too cold, not too hot. This is the treatment algorithm for plaque psoriasis, and I will not go through that. I just want to point out something which for you as community pharmacists, or those of you who are community pharmacists, will be playing an important role. Now, psoriasis could be defined as, or classified from mild to moderate, severe, depending on how much of the body surface area is affected with the skin lesions. Most patients have the mild presentation of the disease, around 80%. And these patients, the topical therapy is sufficient to control the presentation and the signs and symptoms of the disease. Whereas around 20%, they have more severe presentation of that disease, and they will need, in addition to the topical, they will need the other form of therapy, the topical therapy, phototherapy, as well as the systemic therapy. And here we will be talking about these different options and the rationale for using these medications. So starting with the topical therapy, pharmacotherapy, as well as phototherapy. Again, most patients with psoriasis, around 80%, they have mild presentation, and that's why topical therapies alone should be sufficient. We have a list, a relatively long list of drugs which can be used. Here, the first 4 are actually, they have both good efficacy as well as reasonable safety profile, whereas the last 3, salicylic acid, coal tar, and anthraline, they may have decent efficacy, but the problem is that they are associated with serious adverse effects that are limiting to how useful these are. They are almost not used here in the US. In addition to phototherapy, and we have a couple of recently approved pharmacotherapy options I will be mentioning quickly. So starting with the mainstay or the treatment of choice for patients with psoriasis, the magical glucocorticoids. These are both effective and well tolerated with a caveat. So if they are used the right way, the right concentration on the right spot for the right duration of time, then they should do their job well. However, we know that they have potentially a number of potential adverse effects which could be limiting to their role as treatment options. The mechanism of action, they have, as you know, anti-inflammatory, immunosuppressive. They have anti-proliferative effect, which makes them, quite effective in this disorder, because in psoriasis, we have that inflammation plus hyperproliferation of the skin, the outermost skin layer, which gives that, raised skin, the scaliness that is typical in patients with psoriasis. They have a vasoconstrictive effect, which helps with relieving itching. Selecting which topical corticosteroid, this is a big topic. For the time we cannot cover that. But a few important points that we have to keep in mind when selecting the right topical corticosteroid. Potency, it depends on the individual drug. So betamethasone is always more potent than hydrocortisone. Of course, we have to take into consideration the concentration as well as other factors, but this is in general. The concentration, so we have different concentrations as well. The ester form of the drug is also important, and the vehicle. So we have, the ointment, for example, versus the cream. So these factors play a role in when we select the topical glucocorticoid. And this potency, based on this potency, we have different indications. So, for example, the high potency here we can use it for atopic dermatitis if it is resistant. We can use it for psoriasis, but not indefinitely. We have certain precautions when it comes to the duration of how long we can use these drugs. The second choice is the second option is the vitamin D3 analogs, and these are one of the reliable medications. So basically, we have topical form in the form of ointment, calcitriol and calcicotriol. These two, and this is in the form of a foam, these are vitamin D3 analog, and they have a role on inhibiting the proliferation similar to glucocorticoids, as well as promoting differentiation. Again, something that suits the pathogenesis of psoriasis. As you know, psoriasis, we have overgrowth and inflammation. So we need cells that slow down, drugs that slow down inflammation, as well as slow the rate of growth and promote differentiation to have healthy skin barrier. They have also immunosuppressive effect on T lymphocytes. These drugs are generally well tolerated. They may be associated with skin burning or irritation. So something to keep in mind, the vehicle to be kept in mind. When used with phototherapy, they could be deactivated. So we cannot use them with ultraviolet A because that could deactivate these compounds. And I did not mention that their target in keratinocytes is that they stimulate the vitamin D3 there. So they are vitamin D3 analogs. The next option is the topical retinoid, which is a vitamin. These all retinoids, as you know, are vitamin A derivatives. Tazarotene is, it binds to its receptor, retinoic acid receptor on the DNA, and it has also anti-proliferative, keratolytic, and anti-inflammatory mechanism of action by binding to that receptor. And as all of us know, it is also indicated for the treatment of acne vulgaris due to its effect on the proliferation and the keratolytic effect on the keratinocytes. Tazarotene is associated with more adverse effects when it comes to skin irritation. It can also cause skin thinning. This is something it shares with the prolonged use of topical glucocorticoids, which can increase the chances of photosensitization. All retinoids, either topical or systemic, of course, they are pregnancy category X, and reliable and effective contraception is a must. And we all know that, especially if we are using the systemic, then proof of no pregnancy should be provided every month. The calcineurin inhibitors, we have tacrolimus and imicrolimus. These are used topically. They are third-line choice of therapy. And basically, they inhibit calcineurin, which is a phosphatase. And it is involved in the synthesis of a number of inflammatory cytokines. And eventually, this will result in decreasing the immune response in the skin, mainly T lymphocyte mediated. The counseling point, which is important to know, is that these medications are less irritant compared to vitamin D3 analogs and topical glucocorticoids. That's why they can be used in areas where we have thin skin, and that's mostly known as the intertriginous areas, where we have two skins meeting. So, for example, the axilla, the anogenital area, the folds of the breast, these areas we have thin skin, and these drugs are indicated and they are suitable because of decreased irritation. So this summarizes the mechanism of action of these four choices, which are preferred choices. So the topical glucocorticoids and vitamin D3 analog, they are first line, whereas tazarotene as a retinoid, topical tretinoid is a second line, and calcineurin inhibitor is a third line. Of course, needless to say that, the factor of cost is definitely an important one, and it could play a role in which one we select. Again, the main adverse effects, in terms we mentioned that tazarotene is less tolerated. In addition, and this is something I did not mention, high potency glucocorticoids should not be used indefinitely because of skin thinning, striae formation, and whenever we decide to stop them, we have to avoid abrupt stop. They have to be tapered off in order not to cause a rebound in symptoms. The two drugs which were recently approved at the end of 2022 by the FDA for topical treatment of psoriasis is a new class of medication. It's tapinarof, and this sounds like a Russian drug, by the way, tapinarof. It's an agonist of the aryl hydrocarbon receptor, and this receptor plays two important roles. It downregulates pro-inflammatory cytokines as well as promotes skin barrier normalization. And it makes perfect sense that, in the pathogenesis of psoriasis, we need a drug like that. It is still new. And, they mention in the label that it is used whenever the first and second line therapies fail or cannot be tolerated. The second one is a more targeted. It's roflumilast, and this is this class of medications, the phosphodiesterase 4 inhibitors. They have been gaining, track in the recent years, and they reduce the inflammatory cytokines. This enzyme is involved in the synthesis of a number of inflammatory cytokines. For phototherapy, it is both effective and approved by the FDA. We have different ranges. We will not spend much time on them, but basically what we have to know is that we use ultraviolet light with different wavelengths. They have anti-proliferative as well as some of them, they have immunosuppressive effect. And this comes handy in the management of psoriasis. They can be combined with the pharmacological treatment unless they cause deactivation, as we have seen with our vitamin D3 analogs. They are associated with skin irritation depending on how long and how and the dose of the phototherapy. So this brings us now to talking about the drugs which are used systemically for the management of psoriasis. And again, we mentioned that this is for the smaller portion of patients with this disease. So these drugs are collectively known as disease-modifying drugs. So they not only treat the signs and symptoms, but they can slow the progression of the disease. So we have synthetic drugs, which are divided into conventional and targeted, in addition to biologics. Biologics is a big deal now here in the US and worldwide. So for the conventional, we have these drugs which, as the name indicates, they have been in the market for a while. So we have methotrexate, cyclosporine, and acitretin. Whereas the targeted synthetic, we have these drugs which we'll be talking about. Now, all of these drugs are synthetic. The conventional, their mechanism of action is generally not as targeted. So they have this general immunosuppressive effect, whereas the targeted, they have a more immunomodulatory effect. They more specifically target these enzymes or pathways which have been shown to be upregulated in dysfunctional immune disorders. So methotrexate, quickly, it's an antifolate. It is used in different autoimmune disorders, as well as it is anti-neoplastic. It is first-line choice. It has been used for a long time. Its efficacy has been well established. The main thing we have to keep in mind is that we need folate supplementation whenever we use it for long periods of time. It has, as similar to drugs, because of its mechanism of action, it has a number of serious adverse effects as well as drug-drug interactions. Cyclosporine, this is the systemic calcineurin inhibitor. It is an immunosuppressant. It is used also for transplant or graft rejection. It is first-line choice. And again, similar to methotrexate, we have to keep in mind a number of drug-drug interaction as well as potential adverse effects. Systemic retinoid, we talked about tazarotene as a topical. Acitretin is a systemic, and it targets the same receptor, retinoic acid receptor. Again, pregnancy issue, it is second-line therapy, but it is effective and it is used in severe cases. For the targeted synthetic drugs, we have the PDE4, phosphodiesterase 4 inhibitor, apremilast, and this is the systemic part. We talked about the topical one, which has been recently approved. The JAK-STAT pathway, they either refer to them as JAK, which is Janus kinase inhibitors. We have a number of them. This has been recently approved for systemic use of psoriasis. Tyrosine kinase also, it is part of the JAK-STAT pathway, but we have this specific small compound, which is deucravacitinib. And all of these drugs, you see that they have the suffix citinib. We have seen it here with upadacitinib and as well as deucravacitinib. And this one specifically, it is for plaque psoriasis. The biologics, a long list of drugs. We teach them over hours, but I would like to mention a few things which I think will be of importance to you. So these drugs are, made in biological systems, humans, bacteria, animals, and they are selective. So they target the immune system, but at a specific and selective point. That's why they are costly. Their manufacture is costly. One of the drugs which has been recently approved, just to give you an example, one injection in cases of pustular psoriasis, it costs around $53,000 for one injection. So the cost is a big issue. However, they are selective and specific. There are general adverse effects or things to keep in mind when using them. There is increased risk of infection, and this applies to any drug that affects immunity, as well as, we should avoid live vaccines or live attenuated vaccines before, while we start the therapy. A long list. I just want to show you the targets. So basically, 2-necrosis factor alpha, a very important target in dysfunctional immune disorders. Then we have a long list of interleukins. Interleukin 17, 23, 36, and that was the one I told you about, around $53,000. And they have these untraditional names, if I may say. And here I'm including another list of drugs which are used for rheumatoid arthritis, just for completeness. As you can see, the same TNF-alpha inhibitors are approved in addition to other targets. So we have interleukin 6, we have CD20, this is specific for rheumatoid arthritis, as well as CD80/86. So all of these drugs, the point is that we are, again, an abbreviation here. And this is to show that, how we come up with these names. So depending if it's fully human, then they have the suffix. or if it's from animal source such as mice, mostly mice, then this is what the suffix is. And of course, you know, the more human it is, the less immunogenic. It's one of the potential concerns we have. So moving on to atopic dermatitis, and I felt that, you know, the move was swift and smooth. Anyway, atopic dermatitis will not be spending much time. Some of the drugs are the same. I use this as the collateral damage just to help my students remember that we have collateral damage that takes place on the skin. It is unintentional. The immune system is trying to attack the allergen, whatever is causing the dermatitis. Then, because of its overactivation, it's a hypersensitivity disorder, it is causing damage to the skin. So it is not an autoimmune disease. It is a hypersensitivity disorder. It is the most common type of eczema, which is the general term for skin inflammation. And it is usually part of the atopic triad or atopic march, which includes asthma, allergic rhinitis, and usually it starts in childhood, as you can see here, and most children, they grow out of it. So the prevalence goes down as the child progresses. Non-pharmacological treatment, it is very important. Knowing the triggering factor, the social and psychological support. You can imagine, as you know, as a child, they will be avoiding to play with others, avoiding the stigmatization of their disorder, keeping their fingernails filed, skin moisturization. All of these things are very important. They are non-pharmacological, but very important in managing the disorder. And again, something that we as pharmacists can play an important role in. Similar to psoriasis, we have both topical and systemic treatment options. For the topical, very similar ones. So we have the steroids, calcineurin inhibitor, and PDE4 inhibitor. These are all we talked about. Recently, we have JAK inhibitor, which is the Janus kinase. This has been approved, and it is topical. Phototherapy, the same, it can be used. It is although a little less than psoriasis. For the systemic pharmacological therapies for atopic dermatitis, we only have being targeted, which is the JAK inhibitors. For the biologics, we only have 2 so far. As you can see, atopic dermatitis is more a skin disorder. Only in severe cases, we will be resorting to systemic therapy. However, psoriasis is a systemic autoimmune disease. That's why we will be relying more on systemic therapy. So upadacitinib and abrocitinib, these 2 are approved as systemic options for the oral management of systemic atopic dermatitis when it's severe. And as you can see, the FDA is approving them for severe cases which are refractory. The other one is that we have interleukin 13 and interleukin 4. These 2 have been specifically shown to play a role in hypersensitivity disorders. We have these antagonistic drugs. So we have tralokinumab, which is a monoclonal, human monoclonal antibody, and it is as a biologic, it's a subcutaneous injection, whereas dupilumab, it is interleukin-4 antagonist, and it has similar principle in terms of its role as well as importance in atopic dermatitis. We will not be surprised to know that there are other drugs which can be used as off-label. We have a long list of systemic immunosuppressants. These are neither well-studied nor approved by the FDA. And these are drugs, I can understand if they were used in the past because of limited options we have, but nowadays we do have more options, albeit the cost could be high. So I would like to summarize, what we have been talking about. Autoimmune and hypersensitivity disorders, they are on the rise, and there are challenges in diagnosing patients with these disorders. They have a chronic nature, so it's not they are incurable. The cost of therapy could be challenging, especially with the new biologics. And there are certain social and psychological stigma associated with these drugs, which could affect the psyche of these patients. Healthcare providers, pharmacists, physicians, they have a central role in patient education. Patient education is very important in these disorders. The family involvement so that they will provide the necessary support. Luckily, our understanding and management options, they have been dramatically improving. And we are witnessing that with the many available options we have. The disease-modifying drugs are the future in managing these disorders. These drugs are the drugs which are mostly approved every year by the FDA. The companies are rushing to have these drugs, and they are still new, so the post-marketing data will help us understand more about the pros and cons of these medications, but they are definitely still forward. With that, I would like to conclude. I would like to thank you for listening and bearing with me, and we will open the floor if you have any questions or comments.
Thank you very much, Dr. Ahmed. You really made a long story short. It is not easy, I'm sure, to summarize such topic. It needs long time, many lectures to be covered completely. But I am sure you managed to convey the message perfectly to everybody. And at the same time, the lecture, I found it very informative and concise at the same time. Thank you very much for that. And if we have any questions. I have a comment and a question till we receive other questions from the audience. I like the analogy of the disease with the gun. So it is very, I think, very good as analogy to understand the relationship between the environmental factors with the genetic factors. So by genetic factors, we resemble in this case the loading of the gun, while the pulling of the trigger in this case is the environmental factor. So I think this kind of analogy make the sophisticated things easy and perfectly understood by the students. My question that if you have come across any attempt to justify the role of phototherapy in these autoimmune diseases, did you find any justification? Because sometimes our students asked about any possible mechanism behind the role of the phototherapy, UV radiation in such diseases. Did you have any justification in literature?
Sure, Dr. Mohammed. So they cite that the phototherapy in the form of ultraviolet A and B, and we have two forms, narrowband and wideband ultraviolet B light. They mainly have anti-proliferative effect on the keratinocytes. As you know, the keratinocytes will differentiate into corneocytes, the uppermost layer of cells on the skin. And in conditions such as psoriasis, we have that overgrowth of keratinocytes as well as lack of differentiation. So when you slow down the proliferation of keratinocyte, you are giving them more time to differentiate, and that will give a better skin barrier. And that also helps in patients with atopic dermatitis, because the genetic factor in atopic dermatitis patients is that they have a dysfunctional skin barrier because of certain genes, as well as the reduction in the antimicrobial peptides produced in their skin. So this anti-proliferative effect on one hand, which is common between the different UV lights, In addition, we have an immunosuppressive effect for the A ultraviolet light, and that will slow down the immune attack by the immune cells in the skin. So it is both anti-proliferative as well as immunosuppressive, thanks, of course, to, as you know, to the effect on the DNA and therefore the replication of these cells as well as the signaling.
So in this case, tanning has a medical benefit in this case. Yeah. So can we conclude from this justification a correlation between the light therapy with vitamin D, if we kept in mind that vitamin D has conjugated system, and in chemistry that conjugated system can absorb light? So can we say that vitamin D has a photo absorbance ability, and this can act as photosensitizer? And we can we correlate this with the phototherapy, or the mechanism is totally different?
It is different. However, and as mentioned, there is a potential for a drug-drug interaction. Vitamin D3 analogs, they are deactivated by ultraviolet A. So that's why we should not combine these two treatments at the same time. They, either space them. We start with ultraviolet, and later, in 4 hours, maybe give the vitamin D3 analog. In terms of their effect on photosensitization, I'm not aware of anything, but it could be there.
Okay, Dr. Hanif, we have a message from Dr. Nancy Hakouz. Thank you for a very informative lecture. Why do you think that autoimmune diseases are increasing?
Thank you, Dr. Nancy. The exact cause, we are not sure why they are increasing. This is based on epidemiology. However, the most accepted hypotheses include the increased urbanization. People are moving away from, the rural life, village life, where you have that encounter with nature. Your immune system is being introduced to different antigens. So urbanization on one hand, the hygiene hypothesis, the increasingly obsession of cleanliness, detergents. This is also weakening our immune system. We have seen this. I mean, compared to the way we grew up in Jordan, for example, versus how my kids are growing up here in the US, I can say for sure that the amount of antigens, we get if you have this, normal life of going out, playing outside, and not obsessing about these, the hygiene or detergent use, then your immune system will be better equipped. Another factor they mention is the size of the family. Here, here you will find autoimmune disorders and allergies we have not heard about in Jordan or the Middle East. The household size is small. So when you have a bigger family, this means that the family members will be sharing different antigens, and therefore their immune systems will be better equipped to deal with more antigens.
Thank you, Dr. Ahmed. We have also a question. I don't know if you can answer it or not. It is about Jordan here. If the biological treatment available in Jordan. I'm quite sure that you far from Jordan for a while, more than 15 years, I guess.
It's been since 99, so 22 years.
More than 20. Do you have any idea about this?
I honestly tried to, look up some data on the prevalence of these disorders in Jordan, the use of medications. It was somewhat difficult to find, reliable answers. So, whenever I don't find a reliable source, I just avoid using it. However, from my discussions with other colleagues, for them, some of the biologics which have been in the market for some time, we have some in Jordan. I'm sure that it's, having them, will mainly depend on the cost. It's a big issue. It is a big issue here in the US. And but hopefully we have the biosimilars, and nowadays we have a few biosimilars which are the bioequivalent used the generic form of these biologics. For some of them we are starting to have some, and hopefully that will impact the cost of these medications.
Yeah, as far as I know, in our medical insurance system, that it cannot be covered by the insurance, but if the patient is wealthy enough to afford it, then I think he can buy it, but it is quite expensive, as you mentioned. Some people, if they have serious issue, they can buy it from abroad, and in this case, yeah, I've seen some cases like this, but not a part of our regime, and cannot be covered by the medical insurance here. It is quite expensive, not easy to cover it from a third world country. So I think, yes, we reached the point to wrap everything up. I'm sure that this lecture is quite useful and beneficial for everybody. For myself, I've heard about many things for the first time. Thank you very much. And Dr. Nancy, waved to you. And we reached the point to finish the lecture. Thank you very much, Dr. Ahmed. And we will try also in the future to invite you for other lectures. And I am sure all of us get a huge benefit out of it. Thank you very much. Thanks, Dr. Ahmed.
شكرا دكتور محمد، شكرا دكتورة نانسي، دكتورة بيان والجميع، فرصة سعيدة جميعا.